Welcome to the deep dive. Today, we're tackling a condition that I think many of us find challenging. The patient who comes in with really vague abdominal pain, they're losing weight, maybe they're even, afraid to eat. It's a real puzzle.
It absolutely is. We're talking about chronic mesenteric ischemia, CMI. And you're right, the diagnosis often gets delayed, which is a serious problem because it can lead to pretty debilitating symptoms and, worse, acute ischemia.
Right. So our mission today is to really dive deep into the Society for Vascular Surgery's 2021 guidelines on CMI, specifically the kind that stems from atherosclerotic disease.
Exactly. We'll walk through their systematic approach.
Okay, so we'll cover diagnosis, the indications for treatment, how to choose between different treatments, endo versus open, the specifics of those procedures, and then, crucially, long-term follow-up. This is really for you, the specialist, aiming for detailed, actionable insights.
Let's get started. Diagnosis first. 1. Diagnostic evaluation.
Okay, so CMI is on the differential. What's the immediate game plan for a patient with that classic triad, the pain, weight loss, food fear?
The guidelines stress an expedited workup. Urgency is key here.
Expedited meaning?
Meaning quickly ruling out other things, especially GI malignancies. So you'd typically consider things like esophagogastroduodenoscopy, maybe a colonoscopy, definitely an abdominal CT scan, and abdominal ultrasound.
Right, cover the bases quickly because the symptoms overlap so much.
Precisely. You need to differentiate CMI from a whole host of other conditions.
Okay, so once you're working through those rule-outs, what actually clinches the CMI diagnosis according to these guidelines?
It comes down to matching the clinical picture with specific imaging findings. The recommendation is to diagnose CMI if you have that appropriate clinical scenario plus significant stenosis, and they define significant as greater than 70%.
Okay.
Within both the celiac axis and the superior mesenteric artery, the SMA.
Both vessels.
That's the classic picture. But importantly, the guidelines also state you can make the diagnosis with greater than 70% stenosis in either the celiac or the SMA alone.
Okay. So single vessel disease can be enough sometimes.
Yes, especially if it involves the SMA. Let's touch on the why briefly. CMI is basically intestinal angina. The gut isn't getting enough blood flow, particularly after eating when demand goes up. Usually this is due to atherosclerosis blocking the origins of the main gut arteries.
Right.
Celiac, SMA, and the inferior mesenteric artery, the IMA.
But doesn't the body have backup routes? Collaterals.
It does, absolutely. There's extensive redundancy. Think about the connections between the celiac and SMA via the pancreaticoduodenal arcades, or between the SMA and IMA via the marginal artery of Drummond or the arc of Rioline.
So these collaterals usually compensate.
Often, yes, which is why symptoms typically require significant disease in at least 2 of the 3 main vessels. Data from Oderich and colleagues, for instance, showed almost all their CMI patients had significant disease in 2 vessels, and over 90% had major SMA involvement.
But not always 2 vessels needed.
Correct. If the SMA is severely diseased and the collateral network just isn't robust enough, single-vessel SMA disease can definitely cause CMI symptoms. The SMA is just so critical for small bowel perfusion.
And physiologically, what's happening during that post-meal pain?
After you eat, blood flow to the gut, primarily via the SMA, should increase dramatically, maybe double or more, peaking within, say, 30 to 90 minutes. In CMI, because of the blockages, this postprandial hyperemetic response is blunted.
Not enough flow to meet the demand.
Exactly. That leads to the pain, the malabsorption, the altered gut motility, and eventually the weight loss and food fear because eating hurts.
What about the typical CMI patient? Who are we looking for?
Well, the guidelines mention a mean age around 68, 69 years. Most are smokers, hypertensive, often have PA elsewhere.
Standard atherosclerotic risk factors.
Right. But interestingly, CMI seems to affect women more often than men, which is a bit different from, say, coronary artery disease or peripheral artery disease. And another recent observation is that not all CMI patients are cachectic. We're seeing it in overweight or obese patients, too.
That's important not to miss. And you mentioned diagnostic delays earlier.
Yes, they can be significant. One series reported an average delay of 15 months from symptom onset to diagnosis. Part of that is the vague nature of the symptoms, and part is the extensive differential, especially ruling out cancer, which often involves endoscopy first.
Okay, let's talk imaging then. What's the recommended first step for screening if you suspect CMI?
The preferred screening test, according to the guidelines, is the mesenteric duplex ultrasound, or DUS.
Why DUS first?
It's non-invasive, no radiation, no contrast. It's quite good at identifying significant stenosis based on blood flow velocities. For example, in the SMA, a peak systolic velocity, or PSV, over 275 centimeters per second is a strong indicator for greater than 70% stenosis. For the celiac, it's a PSV over 200.
But it has limitations.
Definitely. It's technically demanding, requires a skilled technologist, the patient needs to be fasting, and things like bowel gas or body habitus can interfere. Also, extensive collaterals can sometimes falsely elevate velocities in otherwise okay vessels.
So if the DUS is suggestive or maybe inconclusive, what's the next step for a definitive look?
Then you move to computed tomography, arteriography, CTA. The guidelines recommend CTA as the preferred definitive imaging test.
And its advantages.
It gives you excellent anatomical detail. You can clearly see the extent of the occlusive disease, map out those collateral networks we talked about, assess the vessel wall, and importantly, it helps rule out other abdominal problems that might be causing the symptoms. It's really become the workhorse.
Disadvantages being radiation and contrast, I assume.
Yes, and potential artifacts from heavy calcification or prior stents can sometimes obscure things.
What about MRA, magnetic resonance arteriography?
It's an alternative, especially if contrast or radiation is a major concern. It has good overall sensitivity and specificity. But MRA has its own issues, longer scan times, problems with pacemakers or claustrophobia, it doesn't visualize stents well, and you still have potential issues with gadolinium contrast in kidney disease patients.
And the old gold standard, catheter angiography.
Now it's mostly reserved for situations where the CTA or MRA isn't diagnostic, or, more commonly, when you're planning to proceed with an endovascular intervention at the same time. It's invasive, carries risks like stroke or vessel injury.
So practically speaking, how do we, as vascular specialists, try to shorten that diagnostic delay?
Education is key. We need to make sure our primary care colleagues, gastroenterologists, general surgeons are aware of CMI, recognize the potential symptoms, and understand that often getting a CTA early can be really beneficial in nailing down the diagnosis or ruling out other serious issues.
Okay, quick recap on diagnosis then.
Right. Expedited workup to rule out other causes, especially cancer. Diagnosis hinges on symptoms plus imaging showing significant stenosis over 70% in typically 2 vessels, or sometimes just the celiac or SMA alone. DUS is your first-line screening tool.
Followed by CTA for the definitive anatomical map.
Exactly.
All right, let's try a quick scenario. You have a 60-year-old patient, vague abdominal pain, 20-pound weight loss over 6 months. GI workup is negative. You suspect CMI. What's the guideline recommended initial imaging test? Pause.
That would be the mesenteric duplex ultrasound. It's the preferred screening test to start with.
Okay. Now another one. Patient has symptoms. CTA shows 90% stenosis of the SMA, but the celiac and IMA look okay. Can you diagnose CMI based on this? Pause.
Yes, you can. The guidelines state that significant stenosis, over 70% in the SMA alone with appropriate symptoms, is sufficient for a CMI diagnosis, assuming inadequate collaterals. 2, indications for treatment.
Okay, so we've made the diagnosis. Now, when do we pull the trigger on treatment? What are the main goals and indications for revascularization?
The primary goal, simply put, is to make the patient better, reverse the weight loss, the food fear, the diarrhea, the postprandial pain, improve their quality of life. So the guidelines give a strong grade 1 recommendation for revascularization in symptomatic CMI patients to achieve this.
That makes sense. What about just supporting them nutritionally, like with TPN?
That's a definite no, according to the guidelines. Total parenteral nutrition, or TPN, is not considered an acceptable alternative to fixing the blood flow.
Why not?
Because it doesn't address the underlying problem. The risk of clinical deterioration, bowel infarction, and TPN-related complications like line sepsis is just too high. TPN might be a temporary bridge to revascularization in a severely malnourished patient, but it's not the destination.
Got it. So revascularization it is. Which vessels should we target?
The guidelines suggest the superior mesenteric artery, the SMA, is the primary target.
Primary target, okay.
The celiac axis and IMA are considered secondary targets. Revascularizing them might help if the SMA isn't fixable, or if the technical result on the SMA isn't great, but the SMA is generally the key player.
Based on
Physiology and outcomes data. The SMA supplies the majority of the small bowel and proximal colon. Studies, like one by Goldman and colleagues, suggest that successful SMA revascularization is the main determinant of symptom relief. Fixing just the celiac or IMA alone is less likely to resolve CMI symptoms unless there are specific circumstances, like maybe severe celiac compression from the median arcuate ligament.
What about fixing multiple vessels? If both the SMA and celiac are diseased, should we fix both?
That's debated. Theoretically, restoring flow through multiple vessels seems better, but the evidence isn't conclusive. Studies haven't consistently shown a benefit in terms of symptom relief or survival for fixing both the SMA and celiac compared to fixing the SMA alone. So the focus remains on the SMA first.
Okay, primary indication is symptomatic CMI. Are there other, perhaps less common situations where we should consider revascularization?
Yes, there are a few important ones. First, back to that single vessel disease point. If a patient has typical CMI symptoms, but imaging only shows significant disease in one vessel, especially the SMA, the guidelines suggest a shared decision-making approach. Discuss revascularization. It might be needed if their collateral network isn't compensating, and the procedure could be both diagnostic, confirming the single vessel is the culprit, and therapeutic. This is a weaker recommendation, grade 2, low-quality evidence reflecting the uncertainty.
What about patients without symptoms, but severe blockages found incidentally?
That's another area for shared decision-making. The natural history of asymptomatic mesenteric artery occlusive disease, or MAOD, isn't perfectly defined. Some studies, like one by Thomas and colleagues, found that a high percentage, maybe over 80%, of patients with asymptomatic three-vessel disease eventually develop symptoms.
So watchful waiting is an option.
Yes, and the guidelines strongly recommend close follow-up for these asymptomatic patients, perhaps with annual DUS exams. But in select cases, maybe someone with all three vessels severely diseased, or someone unlikely to follow up reliably, or maybe someone with vague symptoms you can't pin down, you might discuss prophylactic revascularization. Again, a weaker recommendation.
Neither special groups.
Yes, two more mention. Patients with severe MAOD involving the SMA who are undergoing aortic reconstruction, either open or endovascular.
Why consider fixing the SMA then?
Because the aortic procedure itself can compromise mesenteric flow. It can change hemodynamics, or you might need to sacrifice collateral pathways like ligating the IMA during an open repair or covering its origin with an EVAR graft. If the SMA is already badly diseased, this added insult could tip them into acute mesenteric ischemia. So prophylactic SMA revascularization might be wise, especially if they rely heavily on IMA collaterals that will be lost. Shared decision-making again.
Makes sense. And the last group?
Patients who have both MAOD and mesenteric artery aneurysms that need treatment. If fixing the aneurysm is going to disrupt the collateral network that's compensating for the MAOD, then you should revascularize the occlusive disease at the same time. That's a strong recommendation.
Okay, let's try to summarize the indications picture.
Sure. Symptomatic CMI. Strong recommendation for revascularization. Target the SMA primarily. TPN is not a substitute. Then weaker recommendations based on shared decision-making for select cases. Symptomatic single-vessel disease, especially SMA. Certain asymptomatic patients with severe multivessel MAOD. And prophylactically before aortic reconstruction if the SMA is bad and collaterals are threatened.
Plus, fixing MAD when treating aneurysms if collaterals are at risk.
Exactly. It's about relieving symptoms, improving quality of life, and preventing progression to acute ischemia.
Clinical scenario time. 68-year-old classic CMI symptoms, severe three-vessel MAOD, been on TPN for a month because eating hurts too much. Next step according to guidelines. Pause.
Revascularization. TPN isn't the answer long-term. Restoring blood flow is.
Okay. Another one. Patient has CMI symptoms. Imaging shows severe stenosis in both the celiac axis and the SMA. Which vessel is the primary target for revascularization? Pause.
The SMA. The superior mesenteric artery is considered the primary target. 3. Choice of treatment.
All right, we've decided to intervene. Now the big question. How? Endovascular or open surgery? What's the guiding principle?
The absolute core principle here is shared decision-making. It's ungraded, a good practice statement, but fundamental. You have to sit down with the patient, discuss the risks and benefits of both endo and open options, consider their anatomy, their overall health, their life expectancy, and critically, their goals of care.
Okay, so it's discussion. But assuming both are options anatomically, is there a preferred initial approach?
Yes, there is. The guidelines strongly recommend endovascular revascularization as the initial treatment for CMI patients who have suitable lesions.
Endo first. And when is open surgery the better choice?
Open surgery is recommended for patients whose anatomy just isn't suitable for endo. Think really long blockages, flush aortic occlusions, maybe extreme calcification. It's also the way to go if endovascular attempts have failed. And importantly, it should be considered for a select group of younger, healthier patients where the potential for longer-term durability with an open bypass might outweigh the higher upfront risks.
What's the evidence behind this endo first recommendation?
It's based on quite a bit of data, including a large systematic review and meta-analysis mentioned in the guidelines, covering almost 19,000 patients.
And what did that show? Could you sort of walk us through the key findings?
Sure. When they compared open versus endo, the open group had significantly more perioperative complications, about twice the risk.
Wow, okay. What about mortality?
Interestingly, there was no significant difference in 30-day mortality or even 3-year survival. Both were comparable between the groups.
So higher complications with open, but similar short and midterm survival.
Exactly. But here's the trade-off: durability. The meta-analysis found that open revascularization had a significantly lower risk of symptom recurrence at 3 years. It was almost half the risk compared to endo.
So endo is less invasive upfront, fewer complications.
Lower initial risk, shorter hospital stays, often lower initial costs.
But less durable, more likely to need reintervention down the line.
That's the general picture, yes. And this pattern holds up across other studies too, like national database analyses. Endovascular is safer initially, but requires more surveillance and potentially more redo procedures. Open surgery is a bigger hit up front, but tends to last longer.
But the comparable long-term survival suggests that even if endo fails, we can usually salvage the situation.
That seems to be the implication. Endovascular failures don't appear to translate into higher rates of death from acute mesenteric ischemia, likely because recurrent problems can often be managed successfully, often with repeat endo or conversion to open.
So patient factors really come into play.
Absolutely. The best approach depends heavily on the individual patient's anatomy, their comorbidities, which often dictate overall survival more than the revascularization choice itself, their expected lifespan, and what they value most: short-term recovery versus long-term durability.
And you mentioned younger, healthier patients might opt for open.
Right. If someone has a long life expectancy and wants the best chance of a single durable fix, accepting the higher perioperative risk of open surgery might be a reasonable choice, especially given the higher reintervention rates with endo.
This shift towards endo first must have implications for training, right? Maintaining open surgical skills.
It's a definite consideration. As endovascular becomes the primary modality, ensuring trainees get adequate exposure to complex open mesenteric bypasses is crucial, because those skills are still absolutely needed for the patients who aren't endo candidates or who fail endovascular treatment.
Okay, let's recap the choice of treatment.
Endo first is the recommendation for suitable lesions, based mainly on lower perioperative risk and comparable survival despite lower durability. Open surgery is reserved for unsuitable anatomy endo failures or selected younger, healthier patients prioritizing long-term patency, always guided by shared decision-making.
Let's guess this. A 75-year-old patient, CMI, lesions look good for endo, but they have significant cardiac issues. Recommended initial approach. Pause.
Endovascular revascularization. The lower perioperative risk profile makes it the preferred initial strategy here, even with the comorbidities, assuming the anatomy is suitable.
Okay. Now, comparing endo versus open, which one is associated with a lower rate of recurrent CMI symptoms over the long term, say at 3 years? Pause.
Open surgical revascularization. It generally offers better long-term durability and lower symptom recurrence rates. 4. Preoperative evaluation.
Before we jump into the procedures themselves, what about prepping the patient? Any specific recommendations for preoperative evaluation?
Yes, a couple of key points. First, patients should be optimized medically before intervention, but this evaluation needs to be expedited.
Expedited again. Why the rush?
Because CMI can progress rapidly to acute mesenteric ischemia, which is a surgical emergency with high mortality. So while you definitely want to manage their cardiac risk, optimize blood pressure, get them on statins and antiplatelets, maybe address smoking cessation.
Standard cardiovascular optimization.
Right. But you can't afford lengthy delays. If a patient has severe, persistent pain despite bowel rest, that's a warning sign. Nutritional support might be needed pre-op if they're very malnourished, but again, not at the cost of delaying definitive treatment.
And imaging pre-op.
Absolutely critical. The guidelines strongly recommend getting a CTA before any revascularization attempt, endo or open.
Even if they had one for diagnosis?
Yes, or at least having high-quality, recent CTA imaging available for planning. You need that detailed roadmap. The exact location and severity of lesions, the quality of inflow and outflow vessels, any anatomical variations, the status of potential access vessels for endo. If the CTA isn't clear for some reason, then a catheter-based angiogram might be needed.
So recap on pre-op evil.
Expedited medical optimization focusing on cardiovascular risk plus definitive anatomical imaging, usually a CTA, to plan the intervention.
Scenario. Patient with CMI needs revascularization. Their initial diagnostic to US was suggestive but a bit unclear. What's the next recommended imaging study before intervention? Pause.
Computed tomography, arteriography, or CTA. It's needed for detailed anatomical planning before either endo or open repair. 5. Endovascular revascularization.
Okay, let's zoom in on the endovascular approach. You mentioned it's often first line. What are the technical specifics? What kind of stent do the guidelines suggest?
They suggest using balloon expandable covered intraluminal stents. This is a grade 2, weak recommendation based on moderate quality evidence.
Covered stents. Why covered rather than bare metal?
The thinking is that the fabric covering, usually EPTFE, acts as a barrier to prevent tissue ingrowth, intimal hyperplasia through the stent struts. This ingrowth is a major cause of restenosis in mesenteric bare metal stents. So covered stents seem to offer better long-term patency. Studies, like work from Dr. Oderich's group, have shown improved patency comparing covered to bare metal stents in this location.
Makes sense. And procedural aspects, access wires.
The approach is generally similar to stenting elsewhere. Access is usually femoral, sometimes brachial. Brachial can offer a more direct angle to the downward originating SMA and celiac artery. Wire choice depends on the lesion, whether it's a tight stenosis or a total occlusion.
Can we tackle complex lesions endovascularly,
Right.
like flush occlusions?
Yes, experienced centers are treating more complex lesions endovascularly, flush occlusions, long segments, calcified vessels. The long-term results for these more challenging lesions are still emerging, but it's often feasible. Sometimes adjuncts like embolic protection devices might be considered, especially if there's a lot of calcium or thrombus, though their routine use isn't mandated.
Complications to watch for.
The usual endovascular risks,
Yeah.
access site issues like hematoma or pseudoaneurysm, contrast nephropathy, vessel dissection or perforation, stent migration or fracture, distal embolization.
And post-procedure care.
Antiplatelet therapy is crucial, usually dual antiplatelets for a period, then lifelong single agent, though the optimal regimen isn't definitively established. Statins are standard. Diet can usually be advanced fairly quickly once the gut wakes up, and getting a baseline duplex ultrasound soon after the procedure, maybe before discharge or within a month, is important for surveillance.
Let's summarize the endo points.
Key recommendation is suggesting balloon expandable covered stents for better patency. Standard endovascular techniques apply. Post-op care involves antiplatelets, statins, and early DUS for baseline.
Okay, quick question. For endovascular CMI treatment, which stent type is generally suggested for potentially better long-term patency? Pause.
Balloon expandable covered intraluminal stents. 6. Open surgical revascularization.
Now let's shift to open surgery, still a critical option. What guides the choice of which open procedure to do?
It's really tailored. The guidelines state the choice depends on the patient's specific anatomy, their comorbidities, whether they've had prior surgery or interventions, and honestly, surgeon preference and experience plays a role too. It's another ungraded good practice statement.
So lots of options.
A whole toolbox. You have different inflow sources for bypasses, different configurations, and even endarterectomy.
Talk about inflow sources. Where do you bring the blood from?
Primarily two options. The supraceliac aorta, the bit above the renal arteries. It's usually less diseased, which is good, but getting exposure there is more involved, often requiring division of the diaphragm crus. Or you can use the infrarenal aorta or common iliac arteries. Access is easier, but these vessels are more likely to have atherosclerotic disease themselves.
So antegrade versus retrograde flow.
Right. Bypasses from the supraceliac aorta provide antegrade flow, which is physiologically nice. Bypasses from the infrarenal aorta or iliacs are retrograde. Retrograde bypasses might be quicker and less physiologically taxing, potentially better for sicker patients. But there's a theoretical risk of kinking, though techniques like using ringed grafts or specific anastomotic configurations can minimize that.
What about the conduit? What do you use for the bypass itself?
Prosthetic grafts like Dacron or PTFE work well and are commonly used. Vein conduit, like saphenous vein, is usually reserved for situations where there's infection or contamination, or maybe in acute on chronic ischemia settings where bowel viability is questionable.
You mentioned endarterectomy too.
Yes, aortic endarterectomy, basically cleaning out the plaque directly from the origins of the mesenteric vessels, sometimes combined with a patch. This can be a good option, especially in hostile abdomens from prior surgery or radiation, and some series report excellent long-term results.
And again, the question of how many vessels to bypass.
Same story as with endo. While bypassing multiple vessels seems logical if multiple are diseased, the data supporting improved outcomes compared to just bypassing the SMA is equivocal. The focus is generally on ensuring good flow restoration to the SMA.
What about managing patients who present with acute on chronic CMI, where they've tipped over into acute ischemia?
That's a more complex scenario, often requiring bowel resection if there's frank necrosis. Key principles include revascularization, careful assessment of any marginal bowel, maybe planning a second look operation using autogenous conduit-like vein if possible, avoiding primary bowel anastomoses in ischemic areas, and being liberal with that second look laparotomy to check bowel viability again.
And perioperative management for open surgery.
It's similar to other major open aortic procedures. Big focus on managing potential ischemia-reperfusion injury, which can affect multiple organs. Confirming graft patency intraoperatively or before discharge is important. Nutritional support, often starting with TPN, might be needed if bowel function is slow to return. Lifelong antiplatelets and statins are standard post-op.
So the trade-off remains higher upfront risks with open,
Higher perioperative complications, longer length of stay, higher initial cost.
but potentially better long-term durability.
That's the balance, yes.
Let's recap open surgery.
It's a versatile approach tailored to the patient using various inflow sources, supraceliac versus infrarenal, conduits, prosthetic versus vein, and techniques, bypass versus endarterectomy. Key advantage is durability, making it crucial for complex anatomy, endo failures, and selected younger patients despite higher initial risks.
All right. For open mesenteric bypass, which inflow source supraceliac or infrarenal aorta is generally less affected by atherosclerosis.
Pause. The supraceliac aorta, it tends to be relatively spared compared to the infrarenal segment. 7. Surveillance and remediation.
Okay, we've done the revascularization, endo or open. The patient is recovering. What now? How do we manage them long-term?
Surveillance and patient education are really key, given the recurrence rates, especially after endo. First, it's a good practice statement to educate patients about the symptoms of recurrence because they need to know what to watch for.
Makes sense. They need to be partners in their own surveillance.
Absolutely. Then, structured follow-up is important. The guidelines suggest a schedule like see them within a month post-procedure, then maybe every 6 months for the first 2 years, and annually after that.
And what about imaging surveillance? Do we routinely check the repair?
Yes. The guidelines suggest surveillance with mesenteric duplex ultrasound, following a similar schedule to the clinical visits baseline within a month, then biannually for 2 years, then annually. This is a weak recommendation, low-quality evidence, as the direct impact of image-based surveillance on long-term outcomes isn't definitively proven, but the rationale is to catch restenosis early.
Are the DUS criteria the same as for native vessels?
Not necessarily. Native vessel velocity criteria can overestimate stenosis in stented segments or bypass grafts. Often slightly different or institution-specific criteria are needed, or you look for significant interval changes from the baseline scan.
So if the surveillance DUS picks up a potential problem, or if the patient develops recurrent symptoms, what's next?
If DUS suggests restenosis, and the patient has symptoms consistent with CMI recurrence, the guidelines strongly recommend confirming the finding with either CTA or a catheter-based arteriogram. This confirms the diagnosis and helps plan the next intervention.
And how do we treat recurrent CMI?
The recommendation is basically to treat the recurrent lesion similar to how you treat a de novo or new lesion. Meaning an endovascular first approach is generally suggested, even if the original repair was open surgery. If endo isn't feasible for the recurrence, then open redo surgery is the alternative.
What about finding an asymptomatic restenosis on surveillance DUS?
That's another area for shared decision-making. The natural history of asymptomatic restenosis isn't well defined. However, given the patient has already declared themselves as having symptomatic CMI once, many providers might have a lower threshold to intervene on a significant asymptomatic restenosis to prevent symptom recurrence or progression. Again, a weaker recommendation.
Okay, so summarizing surveillance and remediation.
Educate the patient about recurrence. Follow them clinically and with suggested DUS surveillance, baseline, then biannually by 2 years, then annually. If symptoms return and DUS is suspicious, confirm with CT-angio. Treat symptomatic recurrence like a new lesion, usually endo first. Consider treating significant asymptomatic restenosis via shared decision-making.
Final questions. Post-endo revascularization, Patient is doing well. Asymptomatic at 6 months. Suggested routine surveillance imaging. Pause.
Mesenteric duplex ultrasound, or DUS.
Okay. Patient had open bypass years ago, now has recurrent CMI symptoms. DUS confirms a high-grade stenosis in the bypass. Recommended initial treatment approach for this recurrence. Pause.
An endovascular approach. Treat the recurrence like a de novo lesion, suggesting endo first if feasible.
Wow, that was incredibly thorough. We've really unpacked the SVS guidelines for chronic mesenteric ischemia. It's clear this isn't simple, it's complex, it's evolving.
It really is. And these guidelines, while providing the best current evidence, also, point out where we still have gaps in knowledge. There are multiple areas highlighted for future research.
Right. Things like better defining the natural history of asymptomatic disease, optimizing long-term medication regimens, refining surveillance strategies. There's still a lot to learn. But hopefully this framework helps guide optimal care based on what we know now.
So maybe a final thought for our listeners as you reflect on this deep dive. What's one key question or takeaway from these guidelines that you'll consciously bring to your next challenging case involving potential CMI?
That's a great challenge. Thinking critically about applying these recommendations to the individual patient sitting in front of you.
Absolutely. Well, thank you so much for walking us through that. And thank you all for joining us on the deep dive. We hope this provides valuable insights for your practice. Until next time.